Hello, everyone. We are just waiting for others to connect, so thank you for joining us. We'll get started in just a moment. Hello, everyone. If you've joined us, we're just waiting for everyone to get connected to their audio, and we'll be starting very shortly. Well, here's an official welcome, everyone, to our ISPCAN monthly webinar series. We're so glad that you joined us today. ISPCAN monthly international webinars are always free of charge and cover diverse topics and programs, which are presented by subject matter experts from around the world. These 90-minute webinars are designed to help you, our members and partners in the ISPCAN community, gain access to knowledge and expertise to inform care, improve practice, and make professional connections to support you in your profession. All of this is critical to help improve outcomes for children globally. The focus of today's session is to look at child sexual abuse through a case study on trauma-focused screening and intervention. Tips for making the most of today's session. Please engage with us. This is a little different format than what we've done in our past webinars. This session is meant to be an active interactive learning platform. You'll be asked to answer multiple questions, and we would like for you to type your answers into the chat box. Please be ready to make your comments and questions as quickly and succinctly as possible. And we will use these answers to inform the dialogue for the session. Also, please take a moment to introduce yourself to other attendees, our moderators, and our featured presenters in the chat box. Please let us know where you're joining us from, your organization, and your discipline, because we are so glad that you are here. And as always, for joining us today, a recording of this session, the panel discussion, the presentation slides, and links to featured resources will be sent directly to you after the webinar. Our goals for today's session. This webinar will focus on screening, initial response, and trauma-focused interventions for childhood sexual abuse. We will use an interactive, problem-based learning format in which a clinical vignette of a 16-year-old female victim of sexual abuse will be presented and evaluated. Part 1 of the webinar will address the mental health issues that we typically see in cases of childhood sexual abuse, with a specific emphasis on sleep problems. We will discuss challenges in mental health screening in pediatric settings and how to identify traumatic stress symptoms related to remote trauma. And part 2 of the session will focus on how to use trauma-focused interventions to address some common symptoms of sexual trauma, incorporating skills from the trauma-focused cognitive behavioral therapy. And now let's meet our presenters. Dr. Brooks Keeshan, child abuse pediatrician and child psychiatrist at the University of Utah. Brooks provides trauma-informed psychiatric services at Primary Children's Center for Safe and Healthy Families and is the Associate Vice Chair of Child Mental Health at the Huntsman Mental Health Institute. Dr. Keeshan's academic efforts focus on detecting and responding to children, adolescents, and youth at risk for traumatic stress and suicide. He is director of the Utah Psychotropic Oversight Program, which is responsible for ensuring that all youth in foster care receive safe, evidence-based, and trauma-informed psychiatric treatment. Brooks is also the director of Pediatric Integrated Post-Trauma Services, a Category 2 center of the National Child Traumatic Stress Network. And Dr. Lasina Kostova, clinical psychologist and director of training at Lifeline for Kids at the Department of Psychiatry in the University of Massachusetts Chan Medical School. With a multidisciplinary and multicultural education obtained in Italy, Switzerland, and the US, Slatina has a strong background in clinical psychology, and her main interests lie in the area of childhood trauma and mindfulness-based interventions. Dr. Kostova is an international trainer in trauma-focused cognitive behavioral therapy, TFCBT, and an MBCT qualified teacher. She's also a certified trainer for teaching trauma-informed curricula developed by the National Child Traumatic Stress Network, including the core concepts of childhood trauma and resource parents curriculum. On the research side, Dr. Kostova authored several peer-reviewed journal articles, contributed to book chapters, and presented to several international scientific conferences. She's the NCTSN representative in Italy and Switzerland, where she is currently implementing evidence-based treatments for children and adolescents, collaborating with several universities and networks. And at this point, it's our honor to turn it over to Brooks and Slatina.
Maine, thank you so much for that warm introduction. Can you hear me okay?
Yes, perfectly.
Slatina, do you want to say hi so we can make, so you can say hi and also make sure that your mic is going?
Hi, everyone. Yes, thank you, Jane, for this great introduction. Thanks, everyone, for being here.
So I'm going to share my screen. And once I share and get our slideshow up, what I'd like folks to do is, one, make sure that I'm sharing the right thing. So is that the correct one? Correct view? Okay, great. And then what I'd encourage people to do is to open up your chat or expand your chat as big as you can, or to do the pop out so you can see both the screen and the chat if you have two screens. If you're fortunate enough to have two screens, maybe you could have the chat on one and the slideshow on the other. And the reason for that is that we really want this to be engaging. We didn't want to just kind of talk at you for 90 minutes, but rather we really wanted an opportunity to have a conversation about some of these challenges and to follow a kiddo across both a screening and early response paradigm, as well as a treatment paradigm. But it's a kiddo that I think we all could have seen in our different settings, or it could be a family member or someone from our community. So that's our goal, is to really have an opportunity to engage and discuss, but given how many folks we have, the chat will be our way to do that. So we're going to give this a try. And Slatina, I will probably be a few minutes over the 45-minute mark. I might be like 48 minutes. So just based on how we started. So these are our learning objectives for today. And again, just as Jane mentioned, identifying and responding to trauma. And we're going to use sleep as a main construct to show the similarities and differences between early response and more evidence-based treatment, definitive response. But we're going to get started with folks jumping in with this very first question. Please, from your perspective, and we know it's a multidisciplinary group, but we value that multidisciplinary perspective. What are the benefits of mental health screening in general? What's the benefit? And please comment in the chat and please look at what other folks are saying. Early intervention, precision care, making sure we get the proper treatment, understanding resources and treatment, seeing a lot of prevention, a lot of support. Ooh, I like understanding baseline. That sounds like someone who likes to use measurement-based care. They're establishing a baseline. Proper intervention, suitable intervention, understanding an insight. Saving from suicide attempts. Thank you for mentioning that. Knowing who's eligible for different services. Well-informed interventions. So this is helpful. This is a really good place to start. Public awareness. So I like that someone has put in here, like, it goes beyond just the care of that individual, when you screen, you develop a data set that informs public health responses. Measure needed services, exactly. So it's serving the needs of that child, that family, as well as informing broader public health implications. And preventing misdiagnosis. Yes, I couldn't agree more. Right, so we're going to go to the next one. So not everything is great about screening. So what are the challenges of mental health screening? And you can't just say the opposite of the benefits. Judgment, access, language barriers. So Latina, thoughts about kind of what you're seeing in the chat right now?
Yeah, I really, do you want me, Brooks, to read the chat out loud?
No,
or-
just in terms of, I mean, because yeah, I mean, especially like, so like no numerous folks are mentioning stigma. You know, I mean, what does that make you think of in terms of kind of as a challenge with mental health screening? That the stigma itself is the challenge, right? That people are not comfortable sharing, or depending on the circumstances of the community or the culture, you know, feeling judged by the answers.
Re-traumatizing, someone says.
Someone said re-traumatizing. Don't get me started on how screening is not re-traumatizing, but many people perceive it that way. And we need to have open conversations about how it's not re-traumatizing. Fragmented models. So there's a lot of really good comments about it. I think people are focusing on a couple of different major points. One is, I think from a family or child resistance piece, that they are resistant to screening for a lot of maybe preconceived mental health notions, right? And then also there's, I think, some folks who clearly have a lot more public health education and background than I do. And they're thinking about this in a way like, it is not okay to screen if you can't do something about it, right? Screening for the sake of screening, we're just wasting everybody's time. And so if we don't have the right resources, if we don't have a meaningful response we can act on with information about the screening, you know, why are we doing this in the first place? There's been a lot of folks popping stuff up here. So Latina, any ones that you saw that we missed over that you want to really call out?
I was just reflecting on how different cultures and backgrounds can understand screening. And again, me as a Bulgarian who lives in the United States and who also lived in different European countries, I can definitely understand some of those differences, the pure cultural differences, and also based on different professions, how we can see screening as labeling and just placing a diagnosis and stigmatizing. So those are some of my reflections about those differences.
Lots of really good stuff here. Really important things to be highlighted. Yeah. Thank you all for sharing this. So we talk about this kind of broader sense of mental health screening, but another question that we want to get to that's going to lead to what we're going to be talking about today, how does your system, and try to, I know this is hard to say in like just, you know, a very brief statement, but how does your system currently screen for trauma? You know, where you're working. And if you don't screen for trauma, put that, we don't. We don't. trauma self-reported. So some folks are using standardized screeners, some ACEs tools, not yet, but we're ready to start. Hannah, that's great to hear. We don't. Checklists of questions. Some are using groups, ACEs questionnaires, trauma questionnaires, pediatric traumatic stress tool. Ashley, shout out. That's great to hear. That's great. You could give this talk. So school, we don't. Our therapists screen for trauma prior to starting therapy. Excellent. Excellent. So building it within a clinical pathway. Some are using play therapy. Some are using specific types of trauma screening like IPV, objective tests, inventories. So some are using more advanced tools. Some folks are talking about government intervention. Some are using so the CAPS 5, the clinician administered PTSD scale 5, that's a standard, that's actually a structured interview. For those of you who aren't familiar with that one. Someone mentioned the PHQ-9. We're going to get to that. Thank you for mentioning that. Some folks are talking about like when they think there's something going on. So if there's signs or symptoms and they're screening for trauma, and others are taking a more universal approach. Ooh, gamified learning tools. I want to learn more about that. And some are kind of identifying that based on, like, I think the comment coming from Pakistan, I've seen some professionals disregard trauma as something that needs to be addressed. So thank you for feeling comfortable sharing that. And a lot of we don't. Appreciate that. So this is the last question before we get into our case. And I know we're in a whole bunch of different settings, but we're going to talk about sleep today. I'm curious, whatever setting you're in, how do you address if you know that a kid in front of you is struggling with sleep, what do you do? And again, if it's we don't, that's fine. Just let us know that we don't. People are taking longer to type. Understand trauma screening if you find out that sleep is bad. Some are getting clinical, so exploring the routine, sleep hygiene. In child welfare, we rely on specialists, medical doctors. We don't. Some folks are talking about complex trauma, using self-reports. Reassess the child to see if trauma is playing a role in this. Moms are sleeping. And for some, like sleep is that's something that everybody struggles with based on their circumstances and situation, geopolitical factors. Some folks are talking about the environment of the sleep. Great. Refer to a clinical psychiatrist for assessment. So we have amongst ourselves, I think, a very talented multidisciplinary group of folks who are here on the call. And what we're going to do is we're going to talk about this case, and we're going to go through some similarities and differences by which anyone can be identifying trauma and actually even identifying sleep and do something about it. But we're going to talk about how that looks differently as we get into some of the details of our case. When we're talking about our non-mental health folks, those of us that are on the front line, child welfare, primary care, that are seeing kids, versus those that are on the mental health and providing mental health services side of things. So great answers. And I think I'd love to look at this more and get some additional guidance from some of you. some of these things sound really, really helpful. So this is our case. And so get ready. I'm going to go through like 2 minutes of talking, and there'll be another series of chats. Kiddo is Jessica, and we've chosen a kiddo that is outside of the child welfare system. So this is a 16-year-old here in the United States, white, middle class female, private insurance. She engages in sports, and on a normal routine medical screening, they gave her a depression screener, and that's depression screener you can see right here. And also of note, the last question, question 9, thoughts you would be better off dead or hurting yourself in some way. She also answered positively that. And so many places use that as an initial suicide screening question. So right now we have basically a piece of paper that a teenager filled out herself, and she indicated some symptoms of depression and some potential concern for suicidality. A little more information on Jessica. She's had some regular medical stuff. She fell off a playground and broke her arm when she was 10. She's on oral contraceptives. She denies being sexually active. She generally does well in school. Her sister she's close with her family. Not a lot of big red flags. It is documented in the medical record that she actually does have a history of childhood sexual abuse. And I'll just read this last paragraph. The sexual abuse occurred when she was 8. It was fondling by a teenager at a summer camp. Jessica reported that the sexual abuse right away to her parents and had counseling sessions early that fall to address any concerns resulting from the abuse. The patient successfully completed that counseling, whatever that was, and never had any contact with the perpetrator again. So this is the scenario. A kid who otherwise kind of seems like she's doing fine, right? Like there's nothing major. She's here for a adolescent visit, a normal routine medical visit. But she has a history of child maltreatment, childhood sexual abuse. And we have a depression screener that's showing some symptoms of depression and some possible risk of suicidality. So everyone get back to your keyboard. Forward. There's so many things we would want to know, right? But I'd like you all to share with us, like if there was like 1 or 2 things that you needed to know like what the right next step is, like what would be your most critical things that are missing based on what I said that you would want to know in order to respond appropriately to Jessica, because you haven't talked to her yet. You just looked at this information. We got ACEs. We got 1 for ACEs. And if you honestly don't know what else you need, we're here to learn. So please feel free to mention that as well. Family history, something happened recently. What information did she see in the past? Great. Was she medicated? Other violences? Ooh, I like that. How did her family respond when she had disclosed the abuse? Great. She's been assisted. What has she been assisted before and why and who? Has she ever been treated for depression previously? Family history of ACEs, her family history. So a lot of folks asking about family history. Excellent. A lot of folks asking about lived experience. So trauma history or ACEs. Oh, Eunice wants to know, does she have any PTSD symptoms currently? I don't know. Histories, you would want to establish rapport with her. So I like this, engaging. So we're not just like coming in with our one thing that we need to know about. Let's develop a relationship. Let's activate the affiliate response, as many folks at UMass, Slatina's colleagues would be speaking the value of her health history, specific types of feelings like guilt. Does she have plans for the future? That's a great question, especially related to that suicidal piece. Is she having thoughts that are inconsistent with suicide, like future-oriented thinking? So, oh, I love people are putting stuff about the strengths. Yeah. And has something else happened in the past as well? You know, additional, we know about that one trauma, has something else occurred? And does she have someone she trusts to talk to? Again, that's a great suicide prevention question. What is her kind of relational support, the structures in place? Does her family allow her to speak about the past abuse? Thanks, Jane. That's a good one. Yeah, self-esteem, what she would like us to, what does she want? What a novel concept. Like, as opposed to all of us having our kind of, you know, foci. What does the patient or the family want? A great reminder to have that highlight what we need to know. So tons of answers. So thank you so much for everyone who's put in different answers, and a lot of kind of themes around kind of what are other risk factors, family history, circumstances, environment, you know, some things in terms of thinking about specifically around the suicidality. We are going to skip ahead, and I'm going to give you kind of the answer first before going forward. This is a brief validated tool to screen for traumatic stress symptoms. We use this in a modality. We talk about the care process model for pediatric traumatic stress that I might talk about in a little bit. But this was given to her after the depression screening was positive. And I'd like you all to look at this real quick. So it's got a stem up at the top that describes what a traumatic experience is. And it just asks in a very open-ended way, has something like this happened to you recently? Has something like this happened to you in the past? And then it asks 12 specific traumatic stress symptom questions. And it gets scored on a 0 to 4 scale, 4 being more days than not, 0 being never. And it's a validated tool. The brief UCLA PTSD-RI is what this is based off of, which is derived from the full UCLA PTSD reaction index. So as you can see here, and for those of you who remember, yeah, there were depression symptoms. There's a lot of trauma symptoms here. And I want to highlight here that those first 2 questions, not accidentally, are about sleep. And if you're looking at this measure and you're just holding in your hand, whether you're an expert child psychologist or whether you are a victim advocate who's working at a center that provides forensic interviews for kids where there's concerns for child abuse. Yes, this was a self-report measure for the question. Thank you for asking. You can look and see those first 2 items about sleep, pretty high. Pretty high. So a lot of the time, sleep score is 6 out of 8. And so now that we know, so we don't know the totality of everything that's ever happened to her. She didn't report anything else that has occurred since that child sexual abuse at 8. But now that we know about these symptoms, how does that change our understanding of Jessica's case? Because remember, she was a kiddo who was otherwise well, and she had some positive depressive symptoms. That's all we knew, because we had screened her. How does this change what we're thinking about her? Thank you. I want to go back. She's definitely suffered some effect. It informs treatment modality. Treatments and services. Raising the issue about what the relationship is between depression symptoms and the trauma. Absolutely. Unresolved. So maybe there's things that have happened that have not been resolved. Unresolved PTSD. Someone's thinking. The definitive ACEs with sleep effects, potentially affecting whole health, like how you're thinking about more than just the mental health piece, but the health of the whole kid. Treatment of the root cause, not just the symptoms. Don't just give Tylenol for a fever if there's something bad happening that's causing the fever in the first place, right? Yeah. So I really like what people are putting here. You're thinking about, oh, this is going to change how I might approach this. Because, primary care provider, being perfectly honest, I'm a pediatrician, like see someone who's got depressive symptoms, I want to treat their depression. That's a normal human reaction. But a lot of folks are putting in here, like this changes what you might do about her. And a lot of great kind of hypotheses that people are putting in here, like maybe she didn't get good treatment, maybe something else happened recently, maybe unresolved issues. Like there's lots of great hypotheses that folks are throwing out here, and I think that's important to name that, right? It gets us thinking, like what else could be going on, and at the same time, this is objective information that we can actually use to act on, right? We can actually like do something about this when it comes to like, oh, this is changing how I'm going to respond to this kiddo. Trauma-focused services, thinking about the predisposing factors, other factors, PTSD symptoms are apparent. Depression may be a comorbidity. We're going to talk about that. Is depression a comorbidity here, or is it just something called syndromic overlap, where there's actually shared symptoms that exist between both PTSD and depression? And so we talk about comorbidity a lot in adults and sometimes comorbidity in kids, but is this actually a case where the symptoms of depression we saw in the depression screener don't really mean she has major depressive disorder, but rather they were really just the same types of symptoms that are present for her PTSD? That's an interesting construct that I think we'll maybe talk a little bit more about later. Like when you explore item 8 in the questionnaire more. And item 8 was the one where she went back and forth, right? Yeah, yeah, absolutely. I think I love the fact that people are looking at like, are there things that we can take from this beyond just the psychometrics? And I do that all the time. If someone puts all zeros, that's a red flag to me. It's not structured to be a measure to capture underreporting. But all zeros is pretty close to underreporting. All fours doesn't mean that it's the worst thing ever either, right? So I think, when we're using tools, feeling comfortable with them and being able to kind of use them in a way that doesn't just derive a score. But it actually it's a beginning of a conversation. So here's the last thing that I'm going to pop up here. And then I'm going to go through a few slides, and then we're going to get out of the screening and get into the treatment piece. But really appreciate everyone's comments here. So I know we're in all these different settings. What would you do today if we were going to focus on sleep? So we're assuming that the safety piece in the suicidality for right this second is handled. But for the sleep challenges specifically, what would you do today in your setting right now? And if it's that we wouldn't do anything, that's a fine answer too. But would love to learn from folks in terms of what would you do today specifically about her sleep challenges. And we'll give just a minute for folks to put answers in. Therapy, ask about her routine, provide some psychoeducation, refer Jessica to a mental health specialist, right? So some kind of providing additional stuff, some referral, psychiatric therapy. Someone would give relaxation techniques, better understanding, maybe some other types of therapies like support groups. Go back and ask her, so what experiences, rituals does she know? Allow her to talk more about the nightmares. Maybe talking about it could be helpful. Establishing rapport, listening to her, finding out support networks. Explore other things that could be interfering with her sleep. Is there something else modifiable that we could address? Taking her to see a specialist. So again, a lot of referrals, but a lot of folks are pulling in specific things that could be done to address the sleep issue. Ask her what makes her feel good before I'm assuming going to sleep. Like, how can we, that sounds very strength-based. What are the things that work? And let's try to maximize them. Great. So many good things in here. And unfortunately, I am running short on time. So I am, but please, actually, as I start to go in, if there's other things that you would do in your setting about her sleep, please continue to put them in the chat for the next minute or two. But I do want to take a few minutes because we've set this stage to go through just a few minutes of didactics, going to break up the flow for a minute, but then we're going to transition to Zlatina and we're going to talk more about the therapy side of things. So thank you so much for all of those comments. So here's a trauma lens. In trauma, I'm speaking to people who know much more about trauma than I do. So, but this is just to make sure that we're all on the same page about trauma and traumatic stress being kind of that predictable types of reactions to those traumatic events. And if you're a screening person like I am, we think about all these different ways that we can know about trauma, and there's so many different ways. And we can use scales, but it's tricky because there's so many different ways that you can react to trauma. But I do want to highlight on this right side of the column here that, when we talk about the different categories, I really like sleep because it actually connects with two of the different diagnostic groupings of traumatic stress, both the intrusive symptoms, which are captured in nightmares or night terrors, and then the hyperarousal symptoms of PTSD, which are more of the I can't fall asleep, I can't stay asleep, I wake up often during the night. So sleep is very it's cross-diagnostic, but even within PTSD, it crosses different categories. And, a lot of folks don't want to talk about trauma, right? We know this in whatever work that you do, that there's a lot of avoidance, a lot of shared avoidance between families and professionals. But sleep and trauma is intimately woven together. And, we can have a whole lecture about all the different ways in which this occurs, but this last bullet point at the end, that sleep may be an appropriate treatment target for trauma-exposed youth. That's something I think we all need to remember because it might be an appropriate treatment target. It doesn't mean you need to wait until they get treatment to start talking about sleep. So what do I mean about that? Well, we've developed through some of our federal funding here in the United States, a care process model for responding to pediatric traumatic stress. Essentially what it is it's a roadmap that can be utilized in a variety of different settings. A variety of different settings that identifies kind of the key or really the critical steps that need to occur after you screen for trauma in order to appropriately respond to what you're learning about. And so when you think about kind of what some of those components are, this is, again, another version of the same one that Jessica herself filled out. But it talks about kind of we have to screen for exposures, so trauma exposures. And you can do this with a whole long list of types of exposures, or you can do it in an open-ended way. And what we do is we do it in an open-ended way. And then you need to screen at some level for suicidality because of how present suicidality is among kids who've experienced trauma. And frankly, if it's present, it does need to be risk stratified and responded to. And on subsequent webinars, we're going to go into a lot more detail about what that means and how to do that in different settings. But a key piece. But then when it comes to actually using the data, we don't make referrals based solely on exposure alone. We actually need to make referrals based on the combination of exposure and how the child is reacting to having had that experience. And that's where having a standardized approach and built within this tool is that validated UCLA PTSD reaction index, which has been translated into a number of different languages. And I know the developers are very open to helping facilitate other language translations as well. But it's really important to have something objective that we're using as the symptom measure, because it really does, not all kids who've experienced traumatic experiences need to be referred to therapy. So having that, and lots of folks made those comments about how critical it was to, if you find someone who's really struggling, to engage with someone outside of your system, right? But I want to highlight, we don't also have to wait until they get to therapy by responding. We just need to make sure that our response is in line with who we are and what our capabilities are. And so I want to talk to you a little bit about that. So if we're focusing on sleep, and this is what I think we all should be doing. I haven't slept this well since I literally was this size. If we think about the therapy side of things, and I love talking about sleep, we can make it uber complicated. We really, really can. I actually made this figure for a publication, and I'm embarrassed every single time I put it up because it's so overly complicated. But when we think about what are some of the core things that anyone can do to help educate another human being around sleep, a lot of these things are very much within anyone's wheelhouse if they're trained, right? So things at the bottom of this list, we're not prescribing medications if we're not a medical provider, right? Shouldn't be, doing that kind of stuff. But, some of those questions about, like sleep routine or coping skills, if they're feeling really anxious at night, and maybe it'd be nice to learn about a coping skill that might help them calm down a little bit to help them fall asleep. I mean, in the right structure, in the right context, that's something that anybody can teach about. And the cool thing is that that's very consistent with the first components of TFCBT that we're going to learn about in just a couple of minutes. It doesn't replace therapy, but what it does is it pulls forward some of these really fundamental concepts that we utilize in numerous types of trauma-informed and trauma-focused therapy. And it basically provides it in an educational or peer-to-peer supportive format if you're not a clinician, or if you're a clinician but not a mental health clinician. Again, we're not trying to make pediatricians psychiatrists or psychologists, but there are certain things that we can do at our stage if we know that sleep is an issue. If we don't know that sleep's an issue, we can't respond. So we think about kind of this construct, and the way that we use this trauma screener, if we're not in a mental health setting, is basically that same triage tool that I talked about before. Like, it's a way to help engage if someone's having high trauma symptoms, why therapy would be helpful. But it's also ordered in a way that it highlights something like sleep. And what we've been able to successfully show, both in primary care settings, but also in settings with non-clinicians who are doing more multidisciplinary evaluation of child abuse, that we can actually train to one or two very simple techniques that can then be shared with families when they are positive for that certain thing. So we're not asking them to do a clinical evaluation. We're not asking them to come up with a diagnosis, but we're identifying that this is something that they're struggling with. And even from just a basic self-help standpoint, there are things that can work with that. And if there isn't a clinician available, then a victim advocate or another person, a child welfare worker, child protection worker, when they know about that, they can still provide that level of education. Not replacing therapy by any means, but also not having to wait to do something that could be helpful until they get to therapy in the first place. So that's that power of the screening from that intervention standpoint. And I wanted to take just a couple of minutes specific to sleep to really highlight one last thing that a couple of folks did mention in the chat. You might not have seen them because they flew by, but mental health screening and trauma screening are not the same. And I'm going to wrap up my comments with these couple of slides to highlight this one piece that I think is a little bit more on the clinical side, but I think it's good education for all of us to think about. This figure is from a publication we did in American Academy of Pediatrics, in the Pediatrics Journal a couple of years ago. And it really highlights what I talked about earlier in terms of like, where is the overlap between PTSD symptoms and symptoms that we typically think of as depression symptoms. And remember, our kiddo, and you can see here, it really crosses multiple domains of PTSD. It's not just one section, that negative mood section. It's actually in the hyperarousal and increased reactivity section of PTSD as well. You see a lot of irritability, so lots of different overlap, a lot of intermingling of things. And if you can remember from earlier on, our kiddo did fill out that depression screener. And a lot of folks might use something like a PHQ-9 or a PHQ-A and say, that's our mental health screener. And if you say trauma screening, it's like, well, we already do our mental health screener. We're not going to bugger up with anything else, right? This is data from our own primary care clinics here in Utah. And we're gonna, because I'm running out of time, I want to give you the punchline. We have good data to show that if you're located within a healthcare setting where you're doing something like mental health screening, if you're especially not, you're not a mental health provider, you're a medical setting and you're doing something like mental health screening, a lot of the positives for depressive symptoms, those kids actually do have significant traumatic experiences. And a PHQ does not capture one single traumatic experience. It doesn't ask about anything that's happened in your life. It asks about depression, symptoms, and isolation. And then second, when we do this systematically, just within a routine, primary care setting, not necessarily a high risk setting like a center that evaluates children for abuse, a lot of kids have traumatic stress symptoms, high traumatic stress symptoms, and they don't register as positive on a general mental health screen like a depression screener. So these are two really critical points that I think a lot of people conflate mental health screening and trauma screening as being, well, interchangeable. We do one, so we're fine. That's not really true. That a lot of mental health screening that happens in primary care, if you're not screening for trauma, you're missing the boat a lot of times, because a lot of those kids actually have occult trauma, hidden trauma that the system doesn't know about. And then also, a lot of those kids who screen negative for depression screening or other general mental health screenings, not only screen positive for traumatic experiences, they actually screen positive for traumatic stress. And we're missing them if we're not doing a specific traumatic stress screen. And it makes a huge difference in terms of what we do. And this is a very overly simplified side, because it's meant like, we're not trying to make us all psychiatrists or psychologists. But, like, if we go down the wrong pathway and we think this is depression, there are evidence-based things that we can do, and different places do this different ways. But if we miss the trauma piece, we miss an opportunity to go in a different direction. And so many folks, really, I think, highlighted nicely how screening helps you go to the right place, right? Well, the right screening helps you go to the right place. And, I'm all for mental health screening, but I'm all for trauma-informed mental health screening. And frankly, if we're in a site that's only seeing maltreated kids, I think it's really important to think, like, do I really want to take on all the mental health screening, or would it make more sense to really just focus on trauma and traumatic stress screening because of the risk in my population is so high? And so these are things that when we talk about implementation of screening, like we've got a tool that we've developed that has been successfully implemented in very high risk settings, like child advocacy, child protection settings, foster care settings, but it also works quite well in lower risk settings where we're not working with a large abuse population, but there is an abuse population that's embedded within it. But the implementation is different. Either way, we actually want to get the right data to be able to do something meaningfully right now. And that's where highlighting something very simple that we can respond to about something that's so impactful like sleep. If you know about it and you have something in your back pocket you can do, then you could do something, right? And then the second piece is, like, it helps us decide what the right next steps are and who we need to be connecting with. And so with that, I'm going to transition to Zlatina to talk about how we address sleep on the other side when they get to the trauma-focused therapist with this Jessica case. Do you want me to give you control? Would that be best?
That would be great.
Okay, great.
Brooks, thank you so much. I'm impressed with the prediction of your timing, which is great, but also I'm always learning so much from you. And I think some of the takeaway messages was the importance of screening, but also only if we know what we are going to do with it. I also love this expression of trauma-informed mental health screening. Definitely, I will incorporate that into my vocabulary. And I would like to take it from here and talk a little bit about how can we sort of demystify some of the interventions that we can do. And I will talk specifically about TFCBT, which we know it is a specific treatment for childhood abuse, and it is mainly used by psychotherapists. But again, a lot of these skills can be taken by all of you and implemented in many, many settings. So with that, I will start sharing my screen. Okay, I hope you can see this. Great, perfect. So I would like to take you back to our Jessica here and make sure that we remember that what we know so far is that Jess has some concerns for depression, PTSD, and suicidality. She's otherwise doing pretty well. And we do know in terms of trauma history that she had sexual abuse when she was 8 years old. And another stressor right now is that her older sister is going to college. Now, I would like to unfold a little bit more on this case and give you some more information about Jessica that will inform our future interventions with her. And so imagining that maybe you're a pediatrician, Dr. Jackson, or whoever your role is into seeing Jessica, you get back in the room, you see mom and Jess are really relaxed, joking around. And then you let Jessica know that actually before doing the physical today, you would like to talk to her about some of her responses to the screener. And remember, so far you are a little bit concerned about that depression, but also about the significant PTSD symptoms that she's having. So what we know from Jess is that she admits that she feels a little bit more sad lately, but she doesn't think that it's a big deal, which might be pretty typical for a 16-year-old girl. And then she does say that her appetite is down, even though she's still eating. And again, she says how her sleep is being much worse than normal, but she does a lot of things. She plays soccer, goes to school, works, she has a lot of friends, and so she never gets enough sleep. At this point, you obviously want to take the perspective of her mom. And her mom seems really supportive of Jessica. She does say that she had noticed that Jessica is more stressed than normal. She spends more time in her room than usual. She thinks that this might be just teen hormones, but then mom also reports that she and Jessica had a big fight at dinner, and she's wondering if some of those responses on the depression screener that she gave might have been sort of connected with her feeling stressed out, or maybe it's been a really big adjustment, the fact that she doesn't have her older sister with her. So just to summarize what we know so far from the depression screener, we do know that she responded positively, and we know that she responded positively to the UCLA PTSD screening. And as Brooks was saying, there might be a lot of overlap between depression and post-traumatic stress disorder. And definitely one of the main overlaps that we're seeing here is her sleep. Right? And that sleep, those difficulties in sleeping can be explaining a lot of other types of symptoms, lack of energy, problems with concentration, even being more vulnerable to suicidal ideation. So sleep is really, really important. Now, I would also like to hear from you, and I would start with this first question. What would you assess further at this point with Jessica? Knowing what you know so far about her, knowing about her responses, is there anything else that you would like to assess at this point? Current ways of coping. Yeah, great idea. The relationship with her big sister, how does she feel about her sister moving out? What are her anxieties? Social relationships, does she have supportive friends? How she interacts with others? What is the type of relationship with her boyfriend? Exploring phone and social media, absolutely, very important nowadays. Bipolar symptoms prior to the traumatic event, yes, so we want to see if those symptoms were already prior to the trauma. Other risky behaviors, relationship with parents, comorbidities. Does she feel support by her family? Something else that we may want to assess? Functionality of her social support. I'll give you a little bit of a hunch. Think about one of the responses that she gave into the depression assessment. Pro-social skills. Everything that you're saying so far, it's great. But I'm still looking forward to one more thing that you would like to assess in this. Suicidality, Andrea. Yes, absolutely. If we were in person, I would have given some awards here, like candies or something, but I can't throw anything out from here. Absolutely. So we do want to assess suicidality. She did respond positively to some passive suicidal ideation when we were assessing for depression. And so at this point, you are giving the Columbia Suicide Severity Rating Scale, which is something common that we're using here, but I'm sure that in your respective countries, you may have other validated measures. And what Jessica tells you and comes out from this screening is that she does report that she's feeling more stressed, and she reports that she has thoughts that are just coming and going, right? So she does have intrusive thoughts about suicidality. And that when she was 12, she actually thought much more actively about dying. So she fantasized about ways to kill herself. She even wrote the practice suicide notes in her journal. However, even though this active suicidal thinking was back when she was 12, only 4 months ago, she did try cutting, right? So we do have some self-injury behaviors. And she's saying, I was already hurting, and at least I wanted the reason for hurting, but I ended up feeling really silly. And one additional information that we also have here is that the relationship with her boyfriend progressed to the point of already talking about sex. And interestingly enough, some of the times that she feels more suicidal is late at night after a date. I see a lot going on here on the chat. Brooks, feel free to let me know if there is something that I need to capture. Otherwise, I will move on.
No, a lot of folks kind of commenting on other things that would want to be assessed, and which are definitely really kind of spot on. Absolutely. And I just want to highlight exactly what Latina said one more time. Done in the setting in which the suicidality was detected. So you didn't call the psychologist to do this. Like, whoever was asking or reviewing that first question around the PHQ-9, and just to let you know, like, we've trained a lot of victim advocates, we trained a lot of child protection workers, a lot of folks who would never consider themselves a mental health clinician at all, to effectively do this. Now, Latina is giving a lot of, like, this is stuff that you would also experience if you're doing this in a mental health setting. I mean, there's a lot of richness here that Latina has pulled out that you might not, if you're not comfortable, you're not a clinician, but the bare bones of kind of differentiating like passive suicidal only, which is really where Jessica falls, versus more active suicidal that needs urgent response, is something that we all can do, and is something that when we implement the trauma screening piece, that we train to, regardless of the type of the letters behind your name.
Absolutely. Thank you, Brooks, for this intervention. And I will move on asking you now from what you know so far. So we have a lot of assessments, we have a little bit more information. What do you think would be the primary and secondary concerns? If you were whichever professional you could be in that room with Jessica, what would be some of the most important, less important things that you would be already thinking in your head in terms of concerns? Her safety is primary, absolutely, yes. And I think that that's the reason when we think about screening for suicidality, it is fundamental because safety comes first, absolutely. Whether she has got basic requirements, I suppose, support system. Primary would be suicidality, secondary appropriate therapy services. Yes, absolutely. Her safety comes a lot, social support, relationship with her family members, as we know that this is one of the most important factors to help individuals with suicidality and depression and healing. What does she aim for? Yes, as Brooke says earlier, the future-oriented type of thinking, it's a huge predictive factor. Self-destructive behaviors, the cutting piece, yes. Any other risky situation? Is she, I don't know, drinking when she goes out and see friends? Is there anything risky that she's doing? Safety and relationships, environment reaction, coping mechanisms. This is great. I love how active people are independently of the time in your respective countries. Substance use, yes. Is she using anything? Severity and frequency, absolutely. That's great. I think we can stay here forever and then have a great discussion. And I love everything what people are saying here, thinking errors, healthy relationships, staying safe. And again, just to sort of visualize what are we having in terms of primary, secondary concerns. Definitely now we are aware of her history of sexual abuse. We are also aware of some additional stressors, such as the sibling who recently moved to college, all the pressure that a 16-year-old girl can have from school, from job, from a boyfriend who is ready to have sex, the fights at home. And then we also have all these symptoms that we can see on the right side that are her specific symptoms of depression, PTSD, suicidality, with an overreaching sleep issue. And now again, back to you. And I see that there are still some answers from the previous question. But if you think now in terms of treatment, and as Brooke says, we want you to think about not just the treatment for psychotherapy, or if you were a psychologist or a psychiatrist, but what would be some interventions and considerations in terms of treatment that you may think right now? Anything that you would do immediately, or you may think that she will need? Therapy, home routines, education on sex and safety, absolutely, given that she does have some anxiety around that, which might be connected to her previous sexual trauma. Engage her in activities, parents and school interviews. So a lot of you, I like that, are saying to investigate also with school and other people, mental health specialists. Suicide prevention plan, yes. And there are a lot of different safety plans out there that are easily implemented. Psychotherapy, crisis intervention, psychosocial support, CBT, yes. And we'll get into this just in a moment. Feel like I can learn so much from you. Her perception of her adult sexuality. Yes. Another fan for CBT, trauma and suicide prevention, trauma-focused CBT. Absolutely. Now, this is my own curiosity. Again, as someone who lived in different countries, and I just love the internationality of all of you here. I would be curious if you have to think about evidence-based treatments in general for trauma, and for a case like Jessica, what is that you're most typically using in your respective countries? TFCBT, talk therapy. CBT, mindfulness. Yes, I am a big fan of mindfulness as well. EMDR, yes. I'm aware that a lot of people, particularly in Europe, are using a lot of EMDR, cognitive behavioral therapy, EMDR, screening and therapy. person-centered psychotherapy, IFS, internal family systems, yes. CBT, okay, so psychoanalytic therapy, yes. I was trained in Italy, where back in those times, it was very heavy on psychoanalytic therapy, and I love integrated support, so that's great. Person-centered therapy. Thank you. It is really fascinating just to see what folks know and what is used in different countries. And again, while Brooks was talking, there was someone mentioning that there is no one-size-fit therapy. And I want to emphasize that, because again, if I am here also in my role of an international TFCBT trainer, and if we will be looking at TFCBT, again, we're not saying that TFCBT is the only one thing that you can do. So I think acceptance and commitment therapy, Jolly, would be great. Yes, I love this approach as well. Okay, because of questions of time, and I want to make sure that I will be able to actually show you all my slides, hopefully before the end of our webinar, I will move on.
Can I just say one very quick thing?
Yes,
Well, actually, I
please.
don't know if it's quick, but I'll try to make it quick. One person did make a comment, not a lot here, exclamation point. And I think, thinking about the way that we worded the questions, it would have been interesting to think about what types of evidence-based treatments are easily accessible in your setting. Might have been a different answer than what people gave, because I love the answers they gave, but I think we also talk about kind of how accessible are those treatments, which is something that I think we can talk about in the future as well. So I just wanted to highlight that one comment.
Oh, as usual, you're paying attention to the details, which I completely missed in that answer. And I do agree that this is so important, because there will be a huge difference if I ask my Bulgarian colleagues what are some evidence-based treatments in Bulgaria compared to my Swiss colleagues or US colleagues. Absolutely. And maybe that would be a cool question to ask for our survey. All right, now let's talk about TFCBT. I apologize for any redundant information for any of you who have followed our previous webinar. So my focus will be not to just talk about what is TFCBT, but hopefully to walk you through some of the initial skills that TFCBT is offering, and how can we implement those skills independently, again, of your role in the settings that you are working at. And I think that this is where we are moving now in our field, really, especially in our center. We are huge believers that intervention and models like TFCBT should be accessible not only to psychologists and psychiatrists, but a lot of people should be able to get enough training and knowledge about some of at least those basic skills that we'll be talking about. Now, why we chose TFCBT for Jessica and for this particular webinar? Well, this is the most evidence-based treatment for children and adolescents. I might be biased because I am an international trainer of TFCBT, but I'm also very passionate about it because that was the first model that I was trained in, and I truly saw a lot of improvements in children with post-traumatic stress disorder and trauma history. And interestingly enough, TFCBT was actually first created for child sexual abuse. And so I think that it might be particularly helpful and efficient for a child like Jessica. There are a lot of randomized controlled trials all over the world showing significant improvements in symptoms over different settings, over different cultures. So definitely something that can be implemented in any culture and country that you are. There were some great randomized controlled trials in many African countries as well as in Europe. Now, good news, there is an anecdote about TFCBT that initially was supposed to be called trauma-focused component-based therapy. And what I want to say here with this slide is don't worry if you are not a CBTer and if your background is not necessarily in TFCBT. TFCBT is actually a very integrative and hybrid type of treatment that implements a lot of different theories and interventions, from attachment theory to family therapy. There is a huge engagement from the caregiver, and we know again that it's been implemented in countries that are still developing and implemented by people who are more lay counselors and not necessarily psychologists or psychotherapists. This is a map from 2020. The only country I believe here that it's missing is Ukraine. We're doing a very interesting project right now, training Ukrainian therapists. For those of you, I don't know if there are any Ukrainians here, but again, TFCBT can be implemented for ongoing types of trauma. We love acronyms. TFCBT goes by the acronym practice. Today, we will be focusing more on the stabilization phase. So as you can see here, when we start the trauma-focused intervention, independently if it's TFCBT or anything else, what we want to do first is to stabilize our client, right? So we have Jessica here who might have some passive suicidal ideations, and we want to start with that. Sometimes we need to move the future safety, which is the last component of TFCBT, at the very beginning. But today we will be talking about how to provide some psychoeducation around sleep. How can we help Jessica to relax? What are some strategies around modulating her emotions, her affect, and then some cognitive coping. This is a nice visual that is showing again the 3 stages of TFCBT. It is a treatment that can be implemented just in 8 sessions as well as in 30 sessions if it is about some more complex type of trauma. And as you can see here, if Jessica, for example, was a little bit more suicidal and if she was having even more sort of self-harming behaviors, again, we want to make sure that we start with safety, as many of you already mentioned. The last thing that I will say about TFCBT, which we are not going to look at today, but hopefully in some future webinars, is that the most distinctive feature of TFCBT is the trauma narration and processing. Some of you mentioned in the chat desensitization techniques. And so the trauma narration, definitely the mechanism behind it is this desensitization. So we are giving an opportunity to a child like Jessica to tell us their story, and then we are helping them to make sense of that. Now, for Jessica, and for the purpose of our webinar, which is to implement some skills for her sleep issues and to address Jessica and her family at a very sort of first stage, we'll be talking about the stabilization phase. And so what we can do with Jessica, for example, would be definitely providing some psychoeducation, helping Jessica's mom to help her with the sleep or sort of enhance their relationship. We can teach both Jessica and mom some relaxation techniques like mindfulness or anything very simple that they can do. And you can do this in your office. We can teach them some very simple strategies how to regulate the stress that Jessica is reporting. When you feel stress, where do you feel it in your body? How does that stress is for you? Is it more when you're sad? Is it more when you're anxious? And then you can even take it further and talk about how the thoughts of Jessica might be affecting her emotions and her behaviors, and how by changing the perspective, changing the way that we think, often can actually help us to feel better. Now, I've learned that from one of my colleagues here and mentors that Brooks know. And again, when we are in front of a pretty complicated case like Jessica, that is being unfolding in a way that we may have not expected, and we don't know where to start always with sleep, right? So that's the first thing. And also, if you are thinking about the fact that when we start helping people and children like that, if I am, let's say, if I'm not sleeping enough, if I'm not eating healthy, it will be very different for me to think about how can I regulate my emotions or have sort of a clear vision about what's going on in my life, right? And so starting from the very basics and sleep is fundamental, can be a really great place to start. Now, very often, and again, I've been appreciating so much, even if you think about when you go to see a general practitioner or you're going and seeing any other medical professional, how powerful psychoeducation can be. And particularly in TFCBT, sometimes the glory goes to the trauma narration when we get really deep into diving of the trauma. But psychoeducation can be really helpful because this is the first time that we are telling our clients some of the most common reactions of trauma, right? So we are normalizing their responses. Someone like Jessica may feel like she's crazy because she has all these intrusive thoughts and she doesn't know why. She may feel completely broken because she's really scared to even talk about sex with her boyfriend, right? Something that maybe her other peers aren't. And so by providing the psychoeducation around trauma, around sleep, around feelings can really help those children to validate their feelings, something that they might not have ever have felt, reinforce some of the positive thoughts and cognitions that they're having. And we're also starting gradual exposure, right? You're starting to give a vocabulary. Actually, what happened to you is sexual abuse. And I know that Jessica has been going through counseling before that, but you may have a child who doesn't even know that what happened to them is actually traumatic and it's actually have a name of some form of abuse. I'll just give this example that we use in our center here about simply, and Brooks is a psychiatrist, so he can explain this to you much better than I can. But a way to approach sleep, a way to approach hyperarousal is just by asking the person, imagine that you're going for a hike, it's a nice weather outside, and as you're walking, you see this huge snake coming right in front of you. What would you feel? And then let's say Jessica will say, well, I will feel really scared and my heart will start beating, right? And then you can explain that our brains actually releases some specific chemicals when we are in front of a dangerous situation that are helping our body to react and to protect us, right? The fight, flight, and freeze response. And if the threat is continuing, and sometimes that threat can be perceived threat, right? Or a threat of a boyfriend now that it's talking about sex or having intrusive images or nightmares, right? Our brain keeps releasing those hormones. And therefore, Jess, you may feel really unable to sleep, unable to relax. So this is just a very simple example that, again, can be provided very easily in the office. Educating parents. So as we are working with the child, we want to make sure we also work with mom or dad, and we're explaining to them how can you make, for example, bedtime a safe place for your child. We work a lot with foster parents, and so these are some of the guidelines that we give to foster parents. For example, helping the child have a sense of control and ownership in their room, set consistent routines around bedtime, waking up. We know routines are fundamental when it comes to trauma. And then when we talk about sleep and sleep hygiene, I like thinking about activating the five senses, right? So just thinking about how can you activate the five senses and help this child to sleep. So there are some children that may like humming sounds, right? I have a 1-year-old daughter and we have a sound machine in her room that we play every night. But there might be other kids or individuals like me that I would never be able to fall asleep if there is any noise in the room, right? Using smell, if you have a younger child, maybe taking a t-shirt of a parent that may have that smell of the parent, using weighted blankets. Then thinking about touch, right? So there are some routines that people can do, taking a hot shower, for example, before going to sleep, some lotions for little babies, some swaddles, right? That can get that sense of pressure. And then sight. Jessica may have her safe place, for example, the beach, which is my safe place. And maybe you can recommend drawing something or having a picture that she can look at. There are a lot of lamps, definitely not watching scary movies. I was treating one patient with TFCBT, a 9-year-old boy who was having significant PTSD symptoms. And then as we were doing therapy, it came out that he was left in his room the whole night with a TV on and he was watching horror movies. And so, of course, he will be scared. And then taste, right? So some kids may like having water, a cup of water in their bedroom, or drinking a cup of milk before that, whatever it works. There are a lot of relaxation skills that you can use here. And again, Brooks mentioned earlier, you don't need to reinvent the wheel, but even simply asking what works for you, right? What is helping you to relax? Is it music? Is it drawing? Is it even physical activity? Sometimes it doesn't have to be just standing and breathing. You can find a lot of funny things like this object here that, again, you can play on your computer in the office and practice with the child. I think that practicing together can be a great way of co-regulation. So there are a lot of relaxation techniques that we can teach. And I think one of the slides of Brooks was the Sesame Streets in communities, which is a great place that has a lot of videos, a lot of things around relaxation and mindfulness. Now, another piece that we may want to address with Jessica is bringing a little bit more awareness around her emotions. So we know that she's saying that she's stressed. One intervention that you may be already familiar with is the emotional thermometer, right? Explaining to a child that in the same way as our body has a temperature and we use a thermometer, our emotions also have different intensity. And so you may have this handout and just ask Jessica to write down what are the things that you feel when you are really cool, calm, and collected and happy when you're in the blue zone. What are the things that you start to feel in your body, in your mind? What are some behaviors that you're starting to do when your stress is kind of in the middle? And what are some of the things that you do when you are really out of control? I implemented this particular intervention that it's very simple, but it incorporates a lot of different things here that we're teaching, such as the intensity of our emotions and some of the red flags that we may use to understand what we are feeling. We were implementing this in a psychiatric hospital, and it was really helpful for children at different ages. And then the last thing that I wanted to talk today about, and then leave maybe 5 minutes for any questions and answers, is the cognitive piece, right? You don't have to get very specific about it, but even using a very simple tool like the cognitive triangle and explaining to the child and the parent that every type of situation in our life can impact the way that we think. Our thoughts can impact our emotions, and our emotions can impact our behaviors, right? So if Jessica is thinking about her sexual abuse in terms of, I'll be broken forever, it was my fault that happened, probably she will feel more sad, she will feel more hopeless, right? And then her behavior might turn into cutting, into writing suicidal notes, into not being able to sleep. But again, if we can help children realize that actually you don't have a lot of control on your emotions in a way, but you do have the power to change your thoughts, right? And so what might be another thought that we can replace that different one, right? Maybe a different thought could be that it was actually not my fault because nobody has the right to touch a child's privates. And if we have that thought, maybe Jessica will feel a little bit more empowered, a little bit more relief, and then more motivated to use some of those coping skills that we talked earlier. And so just to conclude here, and I'm dying to hear what people think about all these interventions and what people are using already, but just some takeaways. Again, the importance of seeing not just the surface, but going deeper. Not just looking at mental health symptoms, but investigating, is there anything that happens to that child that might be explaining some of the symptoms that we are seeing, but also being aware that we have to know what to do if we're going to ask those answers. Sleep could be definitely a red flag for multiple diagnoses, for multiple challenges, and a very good place to start. Basic prac skills, basic coping skills can be implemented in any settings. Again, you don't need to be trained particularly in TFCBT or even be a therapist to implement those skills. And again, TFCBT is not the only one answer. I saw that a lot of you might have access or having training in another type of treatment. So definitely finding what you feel most comfortable with, what is your style, what are those treatments that resonate more with you, and really believing in what you're doing and practicing together with the child. So thank you so much. I will leave this slide here for a minute for our emails and pass it back to Brooks.
I just got to say thank you so much, because it's so great. Like, I always learn about different techniques like every single time. And, it's great to be learning about like what's happening when the kids that I see are being seen by the therapist. But it's also great to think about, ooh, we could incorporate in that the becoming big and smaller little slide you had with the breathing. Like, I mean, that could be a wonderful tool that could be implemented in a non-mental health setting as a very easy. I did it myself while you were talking, and I also felt more relaxed after having done it. So thank you for sharing that. But I also just want to highlight, like, it's the sharing across this mental health screening to mental health treatment continuum, like having these shared skills that are so critical. But I think it's also so important, like, for us to understand what happens when our kids are going to get there, because then we're able to be better advocates and we're more closely aligned with the families to help destigmatize. Because remember, we had a lot of that anti-mental health, mental illness stigma early on. And then the more that we know and the more we're familiar with things like TFCBT, boy, we're in such a better place to be able to help kind of address those concerns early on, because a lot of those families will just never go to therapy if they don't feel safe enough to let us know that they have those initial conceptions, and they're like, oh, here's a therapy referral, and they kind of toss it in the garbage before they even get to the bus or the car. So thank you so much for sharing all that stuff.
Thank you so much, Brooks. It's always great training together, and I really love our audience and all these comments that I'm seeing, inspiring people to use TFCBT in Brazil, and all that. So that was great. I saw a question, if I'm not wrong, about implementation of TFCBT for online sexual abuse. So I'm seeing this question, and I think that that's definitely something that TFCBT again can be used. Absolutely. We know that online abuse right now, it's unfortunately something very common, particularly with sexual contents and children. So definitely TFCBT can be used for online sexual abuse, and it can be used online as well. There are a bunch of articles and studies that I can share with people if you're interested, but absolutely.
And then please, everyone notice Jane posted, maybe Jane could even repost it again, the SurveyMonkey link. Thank you. It's at the very bottom of the chat now. So to give everyone a heads up, Latina will not be able to be there, but she will be an integral part of this. When we meet at our Congress in Scotland this fall, we will be convening the first work group of folks who are interested in how do we better enhance our mental health discussions, treatment, and sharing across professionals and individuals within ISPCAN. And so, this is a first attempt at kind of getting some stuff out there, but we really want to hear from you all. So please, if you have a minute, take a time to click the SurveyMonkey, whether you're going to be at the Congress and join us in person, or whether we want to hear from you so that we can also elevate your voice too if you can't be there. Because we don't want to just put on stuff that, Latina and I love this stuff. So we're happy to do things that we just enjoy doing, and it's fun working with Jane. But we actually want to do things that's really meaningful and would be helpful to move, your professional development and to move your programs forward. So please click on that link and fill out the form, and we will review all of that before we get to the Congress, and then that'll be incorporated into what we talk about this fall. And Jane, did you have a last thing you needed to?
Well, the biggest thing I want to share is a sincere thank you to you and Latina. You are the most engaging presenters. I hope you saw all the reactions, emojis that were flying, and just, you know, the amount of interaction in the chat really speaks to how engaging you've made this session for us. I also want to thank the audience. Really, you drove this session through your feedback and your comments and your engagement. And again, I think that we probably have about 300 comments in the chat box. So again, more than appreciative of our presenters and of our audience today. And Brooks alluded to it, this focus on mental health is a priority for ISPCAN for this year. And Brooks and Zatina are leading this for us. I did post a link to a previous webinar that we did in November. So this is a series of presentations that we will continue to evolve. Brooks and Zatina really, with the Survey Monkey, want to take what we've had today, what we get in the survey, what we learn in Edinburgh, and continue to evolve this topic because obviously it is critical for the well-being of children everywhere globally. So we're interested in your regional perspectives and your insights based on your multiple disciplines and countries that are represented here today. So again, just a thank you to everyone. A reminder, the follow-up email will have a link to this recording. Presentation slides. I know many of you were asking about some of the things included in the slides. All the links to the websites and resources that were shared in the chat, a link to the previous webinar so you can get caught up between these two. And again, just please, if you could fill out the Survey Monkey link as we keep evolving this topic. So Brooks and Zatina, thank you.
Thank you so much.
Heartfelt.
Yeah.
Thank you, everyone. That was great. And I can definitely feel the energy of people. And I'll be very sad not seeing some of you at the ISPCAN Congress, but Brooks will be there with a very dear colleague of mine who is also a trainer in TFCBT. And I'm sure that he will collect all the information that will allow us to offer more of that. And I'm very much looking forward to it. So thank you.
Thanks, everybody.
Thanks,
Appreciate you.
everyone. Good night or good morning, wherever you are.
Bye. Bye-bye.
Bye-bye.